Good afternoon, everyone. Welcome to the first Humanity at the Heart of Healthcare, or H3 seminar for 2026, proudly brought to you by NHG Group Clinical Education in collaboration with the Humanistic Medicine Institute, HUME, where our tagline is Real Talk for Real Practice. My name is Aaron, Director of HUME, and I'm your host and moderator today. Today's webinar is our inaugural MME-eligible H3 series session. So clinicians who attend at least 80% of this webinar will be eligible for MME points. We have planned 5 MME-eligible H3 webinars for 2026, with e-learning options to follow later in the year. If MME points are important to you, so do sign up for the HUME emailing list, and we aim to support professional development that is both meaningful and practical. At HUME, our approach to teaching has always been grounded in clinical reality. For the H3 series, this means using real-life CEC cases as our teaching material. We believe that learning is deepest not when cases are neat, but when they are uncomfortable, when values clash, time is short, and the one right answer remains elusive. Because these discussions are drawn from real cases, we do ask that everyone engage in the right spirit for learning and improvement, not for criticism, gossip, or judgment. We do not choose ethics because it is easy. We choose it because it is hard. As the very term suggests, ethical dilemmas are inherently difficult because there is often no optimal answer. Trade-offs are unavoidable, and moral regret often lingers. Our hope is not to eliminate uncertainty, but to learn how to sit with it and to support one another when the weight of that uncertainty becomes too heavy for one person to bear. It gives me great pleasure to introduce our speaker, Dr. Giles Tan, ACMB IMH and Chair of the IMH CEC Committee, President of the College of Psychiatrists and Associate Director at the SMA CMEP. On a more personal note, Giles has been a good friend for over 20 years, and we took our MMed Part 1 together back in 1999. Today, Giles will be sharing a case from IMH Clinical Ethics Committee involving a patient with psychiatric illnesses. At this point, I'm reminded of a line often attributed to Gandhi. A society is judged by how it treats its most vulnerable. In healthcare, our psychiatric patients are often amongst the most vulnerable, not only because the illness robs them of their personhood, but because of stigma and misunderstanding and silence. As a psychiatrist working in a general hospital, I'm acutely aware of the sobering reality. Patients with serious mental illness have a life expectancy around 10 years shorter than that of the general population. This is not just a statistic. It is a moral discomfort we all live with as a profession. Our clinical discussion needs no introduction. I'm delighted to welcome also Adjunct Associate Professor Vishal from Tan Tock Seng. Vishal was one of the first colleagues we approached when we began setting up HUME last year. He is a hepatobiliary surgeon with deep interest in quality improvement and ethics. Many will know him as the long-time program director for the PGY1s at Tan Tock Seng. He also holds a master's in ethics and law, and this proves perhaps that ethics is not the opposite of surgery, but its necessary companion. I hope today's discussions will help us reflect not only on what we ought to do, but on who we are becoming as professionals. So over to you, Giles.
Thank you, Aaron, for the very kind invite. Yes, friend of many years. Let me try to share my slides. Can I just check if it's has appeared?
Yes, yeah. We can see them.
Okay, right. So thank you again to HUME and for the organizers for giving me this opportunity to share with you an ethics case that came before us at IMH to our clinical ethics committee. This case we thought would be useful as it highlights the interface between psychiatry and medical surgical care in our patients. It also then throws up certain ethical dilemmas as well as the interface of different legislative operations that we then had to implement, including the MHCTA and the MCA. So let me take you through the case, and then we can have some discussions following that. There will also be a poll to garner the audience your sort of views at that particular juncture, and we'll revisit this after I've elaborated more on the case. So there will be a poll later. Okay, so I will start off with the presentation. So this is a 60-year-old lady with a diagnosis of schizophrenia. She has been on follow-up with hospital IMH since 2012, so well over 14 years, and has been maintained on antipsychotics oral as well as intramuscular depot injection for Pixol. She lives with an elderly mother who has dementia and has 2 sisters who do not live with them. She was recently at that point when the referral came in, been diagnosed with breast cancer on both sides, the right with ductal carcinoma in situ and the right with invasive carcinoma. Following the diagnosis of the breast cancer, her mental condition deteriorated significantly, partly because of the medical diagnosis she received. She presented to our emergency services in an unwell state with pressured speech, increased irrelevance, and was assessed to be in a relapse of schizophrenia. She was therefore admitted under the Mental Health Care and Treatment Act for the inpatient involuntary treatment of the schizophrenia. From the history, the account is that she has been sort of stably unstable for over 8 to 9 years. She has ongoing residual symptoms, including abnormal behaviors like mumbling to herself, making paranoid statements, and having paranoid beliefs all throughout this period, despite being on treatment. The treating team's opinion was that she probably didn't have capacity for several years already to make medical decisions, given the ongoing psychotic symptoms that she was having. And pre-morbid wishes with regards to surgery for her breast cancer, or for any surgery, or for treatment for that matter, was not known to the treating team. Further history from the family, the sister had previously attempted to apply for a mental capacity assessment to take on the decision-making role for her, either as a deputy or with a lasting power attorney. However, and at that time, she also cited the reasons for proceeding with that assessment was because of behaviors, including cutting up to $1,000 worth of cash and purchasing unnecessary items, very disorganized behaviors, leaving food scattered around the house. These questioned her ability to make decisions for herself and care for herself, and so the sisters wanted to take on that role. However, the assessment, unfortunately, was not completed as the patient was not engaging and was absent and did not attend the assessment. So therefore, there was no application for either LPA. If she had capacity at that time, or if she was deemed to lack capacity, then they would have had to go down the deputyship route. But either way, neither of that happened because the patient did not appear for the assessment. So in terms of her management, she was admitted under the MHCTA for treatment of schizophrenia relapse, with the consideration that there were risks associated with her not being able to come for outpatient treatment, partly also stemming from her poor social support. Her mother has dementia, sisters are living apart, and also her refusal for a voluntary admission at that time. So she met the criteria for a mental health MHCTA admission under Form 1, and so she was admitted for involuntary treatment. She was then managed and treated. Antipsychotics were optimized, and then she also went for ECT to try to improve her mental state. At the time also, she was sent for a surgical opinion following the diagnosis, and the surgical team recommended that surgery would be required and indicated and would be in her best interest. The psychiatry team also supported that the treatment of breast cancer would be in her best interest, given that it was one of the stressors that led to her relapse. So there was concurrence between the surgical and the psychiatric team that the treatment of breast cancer would be in the best interest. So there was a mental capacity assessment, and the assessment concluded that patient lacked mental capacity to manage personal affairs and medical decisions. That she did not have enough understanding. There was inadequate understanding of the condition and also the available treatment options. She was unable to retain the information provided by the surgeon or to weigh the risks and benefits of having a bilateral mastectomy against the other alternatives, which may include either hormonal treatment or even not having any treatment. So she was unable to do that weighing up. And also she was unlikely to recover capacity, even with optimization of antipsychotics or an ECT, given that her premorbid baseline over the last 8 to 9 years had been that she had been laboring under significant psychiatric morbidity and residual psychotic symptoms. Consent, in terms of getting consent, the patient adamantly refused all breast cancer treatment. And at that time, her belief was that she would be healed from disciples of God, and viewing the medical care team as performing witchcraft on her. So she was very paranoid. She had her own beliefs about how she can be treated, and also great suspicion of the treatment team's intention of wanting to manage her condition. The family, however, was very supportive of surgery. The sisters were very active in engaging with the surgical team and discussing treatment options with the breast surgery team, and they were supportive with the surgery. In terms of the urgency and the complications, the breast cancer mass was growing, and the mastectomy was fairly urgent, although at that time it wasn't deemed as immediately life-saving or life-sustaining treatment. The dilemma also was that at that time, given that she was in IMH at the time, if she were to go for surgery and she was under the Mental Health Care and Treatment Act at that time, where would she then need to be managed for post-surgical care? And also with regards to her cooperation for the post-surgical care, it did present with significant challenges because there was no certainty, and in fact, every likelihood that she would not engage with the post-op care requirements following surgery, for example, wound management, drain management, subsequent follow-up appointments, even the adjuvant therapy, hormonal treatment, or even radiotherapy, any other procedures or treatment that may be required post-surgery to make these treatments successful. So those were significant dilemmas for the treating teams at the time, both surgical and psychiatric. There was concern also about the psychological trauma the patient may experience, in that she had refused to undergo the surgery, but then might wake up if the surgery was forcibly performed under her best interest with bilateral mastectomy performed on her. So that was a major concern as well on the emotional trauma she may experience. And also she was unlikely to come back for cancer follow-up treatment, as I mentioned earlier. So I come to the ethical issues. I sort of summarized, I presented a synopsis of her case. We come to the ethical issues here. So in terms of the ethical dilemmas, we sort of have, I think, 3 that I've highlighted here. So the first one here is the patient autonomy versus the medical beneficence. The patient's consistent refusal of treatment versus our medical recommendation for surgery. So the patient has autonomy, and her wishes are not to have surgery. The medical team has the medical beneficence principle in mind and would recommend her to have the surgery for treatment of a breast cancer. So the context here is that in the long-standing incapacity with poor prognosis for recovery, even with the optimization of her psychiatric care, means that she's unlikely to regain the capacity. So it's a balancing the respect for her expressed wishes against the clinical consensus on best interest when her capacity is unlikely to improve. So this is one of the dilemmas, and I will sort of encourage our audience to have a think about what are the issues inherent in this dilemma here. And then I'll go on to the next one as well now, which is the individual rights versus the families. We are in an Asian culture and society, and families do play a very major role in our day-to-day life, including in medical healthcare decision making. So in this particular case, the patient's choice regarding her medical decision is at conflict with the family's active participation and wanting her to actually have the treatment. The patient refuses due to her own beliefs versus a family support for the surgical intervention. And this is the context of a patient who is lacking capacity, and we are seeking to act in her best interest and seeking to consult her family, as well as all those who have an interest in her welfare in arriving at best interest decisions. The third one here is the immediate medical needs versus long-term care reality. Whilst we might be able to proceed with the surgery if indeed that was deemed the appropriate course of action, the surgical intervention would have a very high likelihood that the subsequent follow-up care would be not complied with, which would then jeopardize the success of the surgery. Also, that there will be long-term potentially emotional and psychological trauma visited upon the patient if she had refused the surgery and then had subsequently woke up with bilateral mastectomy having been performed on her against her wishes. Okay, and here is where we have the first poll. So I have gone through the case and highlighted some of the ethical dilemmas confronting the medical and the psychiatric teams managing her at the time. So for the first poll, I invite the audience to scan the QR code and share your thoughts at this point. We will come back again to revisit this poll after we discuss and unpack this case a little bit more. So I assume the poll is happening. Whilst waiting, I'll just read it out anyway for those who maybe the screen's a bit small. Even my screen's a bit small, but I'll just read it. Should bilateral mastectomy surgery proceed for a patient who lacks mental capacity to decide on her medical treatment when both the medical and psychiatric treating teams agree that surgery is medically indicated and in her best interest, but the patient has consistently refused treatment, faces risk of being traumatized by the procedure, and is unlikely to return for post-op care treatment follow-up, while her family also at the same time supports the surgery. So that is the poll. So we'll give some time for people to answer that. Okay, so we give a bit more time for the numbers. Oh, we're almost evenly split. Okay, shall we give maybe another 30 seconds and then we can go with the numbers. Okay, so maybe we can go with this rough breakdown, which is roughly close to evenly split, slightly larger group saying not to proceed, and slightly below for 50% saying to proceed. Yeah. Okay, so I will reshare my slides again. Okay, right. So so we carry on with the ethical analysis now that you're familiar with the case and the ethical dilemma that it presents. So we can use the 4-box approach where we put the medical information, the relevant information into each of these boxes, which is the medical indications, patient preferences, quality of life, and contextual features. Each of these boxes would be encapsulating some of the principles inherent in the ethical analysis. Medical indications, we are looking primarily at beneficence and non-beneficence, patient preferences mainly on autonomy, quality of life, again, beneficence, non-beneficence, and then contextual features will include issues relating to distributive justice and other relevant factors. Okay. So in terms of medical indications, there is the breast cancer diagnosis as well, and therefore needing surgical intervention and treatment and post-surgical follow-up. The breast cancer mass is growing, and the surgical opinion is that it is fairly urgent and requires mastectomy for treatment. In terms of the indications for intervention, both psychiatry and surgical teams recommend surgery as medically indicated, not just for the treatment of the breast cancer medically, but also for the mental state, given that the ongoing physical condition is exacerbating her psychiatric condition. The surgery is not life-sustaining treatment, but addresses significant health risks. The post-op care requirements, as I mentioned earlier, is a significant concern, whereby there will be significant requirements to comply with wound management, drains, follow-ups, and as well as a subsequent adjuvant therapy. The patient preferences, the patient does not want the breast cancer treatment or surgery. She has been quite consistent in saying that. These are expressed wishes. And has her own belief that actually healing will come from the disciples of God and not from the treating team. The patient also views the medical team as with great suspicion and views whatever they do on her as witchcraft. And her pre-morbid wishes regarding medical or even surgical treatment are not known to us. So these are just a summary of some of the facts putting into different boxes. In terms of quality of life, she has been, in a stably unstable in a sort of mental state with residual symptoms for the last 8 to 9 years. There has been significant mental state deterioration following the cancer diagnosis more recently, necessitating inpatient treatment under the Mental Health Care and Treatment Act. Potential features-wise, she lives with an elderly mother with dementia, and there is limited caregiving support provided for her to come for her outpatient treatment and visits and follow-up care. She's currently detained under MACTA for compulsory inpatient psychiatric treatment given the relapse of schizophrenia. Her sisters are actively supporting surgery and engaged with the surgical team. Sisters have previously attempted to have some apply for a deputyship but were unsuccessful as patient did not turn up. Therefore, there is no legal representative or guardian for her by way of either an LPA or a deputyship. Okay, so here is where we have the poll again, where I'm hoping you have had a little bit more time to sort of mull over some of the issues and some of the ethical challenges that we were confronted with. So we will run the poll again to see whether there's what the results we see this second time round, and then we'll then open it up for some discussion. So as before, please scan the QR code and please share your opinions, whether your opinion has shifted at all or it is still the same. And then we will then have some discussion. Okay, so thank you, audience, for being so game and engaging and taking part in the poll. I think we still see a preponderance of those saying no, but I think the numbers saying no have now gone up slightly from 50-something now to 60 and above. So I think there has been some slight shift in terms of viewing whether or not to proceed with the breast surgery, and I think a larger number now view that not to proceed might be the best course forward. Okay, so let's. Yeah. Okay. Right. Okay. So these are the questions to sort of bear in mind, and then we can have the discussion. So what are the ethical considerations of performing medically indicated but not life-sustaining or life-saving surgery on a patient who lacks capacity, who has unknown pre-morbid wishes, although now is objecting? Should the surgery be denied to a patient lacking capacity due to concerns about post-operative compliance? And should family wishes and medical recommendations override consistent patient refusal when long-standing incapacity prevents a valid decision-making on the part of the patient? So these are some questions to bear in mind. And with that, I will hand over to Aaron for the further discussion.
Thanks, Giles, for a comprehensive walk through the case. I think the four-box approach ends up being very interesting, or becomes much more interesting when we start teasing and looking at the details, because really the devil is in the detail, and the individual cases will have possibly different outcomes based on the interesting details. At Hume, or at our webinars, there's this very interesting phenomenon. I guess we come up with very challenging and thought-provoking titles. And so people actually ask questions even before they heard you speak, Giles. So we had a few questions beforehand. And so because of that, and some of the questions that were coming in are aligned with the, I guess, the theme or what we want to be discussing on. So I can start the panel discussion I can start off the panel discussion, but I encourage the audience to actually put in more questions in the group chat if possible. So there was an audience question even before the webinar started, giving a background. The case, at least the case vignette that was given to him, made him think of a Jehovah's Witness and the refusal of blood products. And so applying applying it into this particular case, two obvious questions are emerging. The first one is really, how do we tell if this person's religious beliefs, or is it due to an underlying psychiatric illness as the patient is in a state of relapse? I think Tim as well as Shi Hui had sort of alluded to this. So maybe I start with Giles, and then we have it as a discussion. We can bounce off each other, because further questions will come in accordingly. So Giles, maybe with this particular view, I mean, Shi Hui asked, how do we know this is not schizophrenia? Tim was asking how much of it is really this, could depression be an issue here? Maybe you can kick the start the discussion by addressing that question.
Yeah, okay. Well, okay, thanks. That's a good question, because religious beliefs are beliefs, right? And I think in the context of this patient who has schizophrenia, the question is whether or not this is part of the schizophrenia psychotic symptoms, whether or not it is a delusion. The definition of a delusion is that it is actually unshared. So if actually her religious beliefs are actually shared by a community or a group of like-minded individuals, then actually it is not pertaining specific only to her beliefs, then it will not be deemed as a delusion and may not then necessarily be part of the psychotic symptom complex that forms schizophrenia. So I think that probably is a sort of psychiatric way of looking into it. However, beliefs do influence the way people then reason and weigh things up. And so the deeper question is also then, does the belief influence the weighing up process? We know in the Mental Capacity Act, the capacity is where the patient is able to understand, retain, weigh up, and communicate the decision. So where the belief or the lack of a belief of the information that they are provided to allow them to weigh up is then they're not then able to make use of the information because of a lack of belief, and whether or not that significantly impacts on the belief, the weighing up process, and whether that then affects their capacity. I think that perhaps is often a subtle, a very nuanced assessment that needs to be undertaken. So I'm not sure whether I've addressed it sufficiently, but feel free, Aaron, to add in your psychiatrist too.
Vishal, is there anything to add on in terms of how you see this? I mean, again, the audience, this is a bit of a general audience. They are talking about a person with a Jehovah's Witness, clearly has religious beliefs, and then refusing treatment. Maybe you can weigh in from that point of view, apart from just a pure psychiatric sort of evaluation.
Yeah, thanks, Aaron. I think people can refuse either for a good reason or no reason at all a treatment which is beneficial to themselves. And I think refusal wouldn't automatically qualify them as lacking capacity per se. So I think we have to probe deeper on the reasons and logic for refusal. And if this is purely established on religious grounds, we then need to work with the patient and or family members to either break the glass or we have to find something which is a little bit acceptable mode. For example, if they don't accept blood, whether they are able to accept the iron injections or some other alternative choices, which may be a little bit less effective, but also reasonable and valid. So in that sense, yeah, we have to explore a little bit further the reason for refusal and see if we have other alternative options, even if they may be a little bit less efficacious. And finally, I would add that if we strongly believe something is really essential, and there is an impasse between the patient and family, and patient is competent adult, and we strongly believe you have to respect the wishes. Very rarely, I think in UK, there are a lot of precedents of people going to the court, and I'm aware of many court judgment where the hospital will go to the court and get a court directive to actually go and proceed with the transfusion. Some of these are actually landmark cases, especially in pediatric arena. Over to you.
Thanks, Vishal, Giles, for the discussion. From my point of view, I guess in terms of what Shui as well as Tim is actually mentioning, it is the individual patient. So I guess we want to know how religious she was beforehand, what sort of religion she was participating in. Was it, I mean, in our culture, we are multi-religious, whether she's a Christian, Buddhist, Taoist, so on and so forth. This will give us a bit of a background and how staunch she actually is, right? Does she attend church? Is she baptized? And so on and so forth. The other thing is, of course, her experience with things like witchcraft and spiritual healing. So these are the type of details I would think that would be important for us to try to really tease out whether this is really the authentic wish of the person or whether she was laboring under the delusion where she's hearing a voice saying that this is witchcraft and so on and so forth. And to Tim's point, I mean, in the questions, whether or not there's a depressive element to this. So again, from the cultural point of view, whether it is an acceptable sort of religion from Vishal's point of view, assessing really why does patient want this particular type of situation, but also from the individual patient's point of view, as Amin had actually mentioned, maybe corroborative history from the family, maybe understanding what she was like and how she developed her religious experiences and how she developed her religious beliefs, that will try, even though not perfectly, help us tease whether this is her authentic wish based on religious purposes or otherwise. There was another question, quite a nice question that actually asked, are all supernatural beliefs classified as mental illnesses? Well, to be fair, I have a story on this. There was this patient just over the New Year who actually said, I want to go to Woodlands Hospital for admission because I really have sixth sense. Since young, I could see ghosts while in hospital and around. And so the patient was actually referred to psychiatry, and I happened to be on call on the weekend. Just to cut a long story short, there's such a thing as a culture-bound syndrome. So back to what we mentioned before, if you have beliefs that you have grown up with related in keeping with your culture, function is actually very much maintained. No, the answer is no. Not all supernatural beliefs will be labeled as a mental health issue. Good story. The story is that we facilitated the patient to move over to Woodlands Hospital because he thought it was a newer and cleaner hospital. So the element, I guess, to a certain extent here to further deepen this discussion would be really in this particular case, right? The complexity of the decision and the fluctuating nature of her illness. Do you have any comments on how we actually deal with such a patient, right? With fluctuating consciousness, fluctuating capacity that is related to relapse, possibly delirious process, possibly related to stress. How do we increasingly deal with such patients that may be fluctuating in terms of their level, their ability to cope or ability to engage as we deal with chronic illnesses, both on the medical side as well as the psychiatric side? Maybe, Vishal, do you want to take that? What is your take on, let's say, a delirious patient that on one hand, on one moment can give consent, then when turns delirious, he can't give consent. And then, of course, the joke in the past is we wait until the patient loses capacity, then we do what we want. I mean, this is a sort of a archaic type of thinking, but certainly I would like to hear your point of view and how you actually see or decipher or how you work around this problem.
I think there are two aspects here. One is how we should be doing, and number two is what we do on the ground, because this is a fairly common situation. I've consulted somebody for hernia or gallbladder or even colonoscopy in the clinic, just to know that on the day they come to anesthesia appointment or on the day of procedure itself, they say, I don't know, why am I here for? And then we have to determine whether this is a fluctuating capacity or complete lack of understanding out of knowledge gaps or conversation or communication gaps. So in Tantoxin, I think many of us will then resort to two consultant signature and proceed. That's what happens on the ground, which is probably an act of convenience. It may be true on many instances, but a little bit of act of convenience. I think ideally we still need to determine what is in the, as Giles has put down the 4-box approach. We still have to go back to the basics and start the working again. When we did 4-box in some instances of acute appendicitis and all that instances, it takes 2 to 3 hours to determine the entire 4 boxes. Because the ingredients of the 4-box is just facts of the matter. You need all the possible facts. And sometimes in ethics, we might be surprised, though we feel we know a lot of things about a particular patient and the case. Actually, we don't know a lot of things. So facts are very important. And that's why the clinical ethics committee tend to be of diversity. So including not only the clinicians, but also lay people, lawyers, as well as social workers, and so on. And increasingly, there is a push towards even family members to be included into the ethics committee deliberations as well. So I think not so simple on the ground, but at least if you have a framework on how to handle such issues, it can guide you to make a reasonable clinical decision at the bedside. Over to you.
Giles, any comments? I mean, as I pointed out to you, in terms of not having capacity broadly is something that the law doesn't actually give. Although we clinically, given the severity of this unfortunate lady's illness, we tend to lean towards the fact that she doesn't have capacity. Any comments on that, Giles?
Yeah, I'm intrigued by this your earlier question about the fluctuating capacity. And that I think one important point to note also that I mean you jokingly said we will wait for that lose capacity, then we just do whatever we need to do. But actually the expressed wishes from the patient when they did have capacity is still valid even after subsequently they lack the mental capacity from delirium or whatever. So we still need to respect the decisions made whilst they have capacity, and these preferences, in fact, these decisions that they had made continue to continue to be important, and in fact continue to have authority even if they were to lapse into incapacity subsequently. I may also just add to this that I suppose in the UK there was this landmark case, right, in 97, this VMB case where this patient actually had wanted a cesarean and agreed to the cesarean, but unfortunately has severe needle phobia. And I think it was Lady Butler-Sloss at that time who said that, okay, we acknowledge she has capacity, but at the material time when you do need to do the surgery, she will refuse because she cannot, she will say no the moment she sees a needle. And so they said, at that point, she would be rendered as lacking mental capacity, and then it would be in her best interest to then do the cesarean. So I think in that case, they also emphasize the importance of respecting the patient's autonomy when they have capacity, which is actually she wants a cesarean section. But at the point in time when the needle is produced and the procedure is to start, she will then be rendered as temporarily lacking capacity. And so they would then act in the best interest and override that. Yeah, so I think that's just I suppose useful case to note, from the UK legislation. Coming back to this patient, I think it's a constant dilemma because severe mental illness does impact on mental capacity, the capacity to make decisions, and also especially when these decisions pertain to medical decisions and physical medical care. We know that MHCTA only allows psychiatric care. I think that's a very important point to note. It does not allow us to use MHCTA to involuntarily admit somebody and then provide medical treatment which is not actually related to her psychiatric treatment. So the MHCTA does not allow us to do that. So in fact, we are then relying on the MCA. So the mental capacity. So we're again relying on whether or not this patient has capacity. If she does, then we have to respect her autonomy. And as Vishal mentioned earlier, one of the core principles of the MCA is that the people have the right to make unwise decisions, or what we deem as unwise decisions, if they have the capacity. So we have to respect that. But if they do lack capacity, then we have to act in their best interest. Now the mechanics of going about as determining best interest is itself also not so straightforward. And we have so many competing considerations to take on board. And even if it's in her best interest to have surgery, what about after surgery? What about the post-op care and the follow-up care that is needed? Now, if the whole package is not looked at in totality and we just say surgery is the decision, then we go ahead, then in fact it is bound to fail because all the follow-up that is required is not complied with. So, it's not often so black and white, and in fact, it's many shades of gray, and it does require many consults and many views sought and careful weighing up. Thank you. Sorry, very long answer.
No, not at all, Giles. I think you jumped the gun because one of the things that we wanted to speak about was because the contextual issues, and in this complex case is with regards to the Mental Health Care and Treatment Act and how it interplays with the Mental Capacity Act, what duties that are residing with the Institute of Mental Health, and then what once the patient leaves, what powers and duties reside outside of the hospital, and it, to a certain extent it alludes to how sort of tight sort of collaboration and communication is actually required between the acute hospital and patients with such severe or serious mental illness. There was a question, I guess, that was related to that as well, in terms of the Mental Capacity Act, the Mental Health Care and Treatment Act, to a certain extent empowers us to act in the patient's best interest and therefore involuntarily enforce some form of treatment for the patient. There was a question here that actually, in terms of following up, is that, I guess, apart from the power to do that, how do we best ensure or how do we engage patients to help with adherence with treatment? So the act actually gives us the power to do it, but on the ground, clinical practice, how do we actually improve adherence? I guess the questioner actually said, how do we improve compliance? But I guess we are moving away from the word compliance to adherence, because I guess compliance suggests a power difference, a pejorative, more negative language, negative connotation. So in spite of that power difference in ability to enforce either through the MCA or the MHCTA, what are the on-the-ground ways in which we can actually improve adherence for such patients? Anyone, Giles or Vishal, any comments at all?
I can have a quick stab at this, and then Vishal, please jump in. I think really building trust and having that therapeutic rapport with the patient is absolutely critical. I think we have the rapport with our patients. Our patients trust that we are acting in their best interest, that we are there to help them. I think that helps a lot. And to do that, you also need a lot of patient education, psychoeducation, a lot of patient empowerment. Also, speaking a language that the patient understands, coming at a level, we are often guilty of using a lot of jargon and not being very clear in explaining things to our patients. So actually being able to bring it in a very clear way, putting it in terms that are relevant to them and material to them, and also building that trust that the treating team actually are looking out for their best interests. I think these are very important elements, but ultimately we also should not cross the line, coerce our patients, and arm twist them into doing what we think is best for them. Sometimes I know it's not easy. The number of times I've wanted to pull my hair when, clearly it's so obvious, it's so logical. Any logical person would see that the right course of action is what I've just proposed. But the patient, for their own reason, when they have capacity, does not agree, does not see eye to eye with that, and actually refuses. And I have to respect that. So I think having the respect for the patient, being able to support them, giving them information and supporting them to understand the information, and oftentimes involving others in shared decision making, and also families, as we mentioned earlier, is a very important part of the decision making process. And I will encourage that as well. They can talk to family and friends, they get second opinions, all that sort of thing. And then hopefully at the end of the day, they come to a decision that they have arrived at through careful consideration, and we have to basically respect that and work with them. Our duty of care also does not end just because they refuse the treatment. We continue to have the duty of care to support them, and also sometimes refer them to other interventions if that's what they require. Thank you.
Vishal, anything to add?
No, I think Giles has summarized very well, essentially, basically trust, rapport, and giving empowerment and listening to patients and showing our presence that we are for them. And of course, then the adherence will probably be boosted, though it doesn't guarantee, but it probably is as good as it gets, I guess. Over to you.
Yeah, I think we have all experienced patients who disagree with us, don't agree with the illness, especially for those with mental health issues. But because of the rapport you have with them, they take their medicine, they agree to the injections, and they come every week to see you. They still bring you oranges over Chinese New Year and wish you well. So we do have such patients that are unusual in terms of the insight to the illness, but yet the rapport wins the day, and the relationship actually wins the day. I'll move on to another question that had come from the audience, and I'll link up to some of the issues that actually are being brought up in the chat. One question that was asked is this: if parents are LPA donees but refuse medically beneficial treatment and the patient lacks capacity, can they be overridden? So again, applying it into this particular case broadly, in this case, based on principles and your sense of what to do, the question is, at the end of the day, who decides for this patient? Who decides that the operation needs to be done? Anyone wants to think about the situation? And of course, someone in the chat asked curiously, what was the outcome for this case? Because I think the person also had a very similar fungating tumor patient and was interested in knowing the outcomes of how actually it was actually managed. Anyone wants to jump in? Vishal or Giles? Anyone wants to jump in? Who decides in general, and who decides based on your opinion in this particular case?
Maybe I'll add a little bit and then Giles can chip in. So from the surgical point of view, I think it's important that we all understand that the final decision making is the consultant in charge of the patient. So a surgeon is not able to delegate the decision making to either the psychiatric team or to the clinical ethics committee. So that must be very clear. So if there is a breast surgeon involved and the patient is under the care of a particular breast surgeon, at the end of the day, it is the breast surgeon's responsibility and accountability for the patient's final decision made. The clinical ethics committee or the psychiatric opinion only forms some form of recommending guidance as to probable course of action. So I think that clarity has to be there with all of us. Now, I think in this patient scenario, while we are all blinded to what actually happened, because Giles has kept that enigma going on, but I would actually have 2 or 3 interesting perspectives. First is this patient believes that the treatment will be done by disciples of God. And many of us in this forum would also consider ourselves as disciples of God, because not too long ago, doctor was equated to God because of the nature of the work or professional duty. So that's one. So it's not entirely against the professional perspective as well. The second is patient use the word witchcraft. While we will exclude the witch, but we also believe art and craft of medicine and science. So in that sense, there is some craft involved. And these are all alignment with patient's perspective or patient ideas as well. And I wonder whether such things were probed with the patient during the encounters and transaction. And last but not the least, I know the dominant discussion was about surgery and mastectomy and disfiguring surgery. and after treatment. But there are some least invasive or lesser restrictive options which have, in terms of Mental Capacity Act, we'll say least restrictive choices. For example, rather than removing somebody's appendix, we can just treat with antibiotics if it is not perforated. So in this sense, whether the tumor was ERPR positive, they were HER2. So more scientific data points to see non-surgical options were even worth a consideration. So those would be my quick points to discuss. Over to you.
Thanks, Vishal. Yes, I think you covered the area whereby the patient lacks capacity and best interest decision needs to be taken, the decision maker being the breast surgeon, having consulted, and gotten views. I think the audience also asked about if there was a legal representative, for example, there was an LPA and there was a donee, and the donee was, let's say, refusing the surgical intervention, even though it was deemed in the patient's interest. So I think in that scenario, if the patient lacks capacity and there's a legal representative, there's a donee who has powers over personal welfare decisions, then yes, that donee can make healthcare decisions. However, the responsibility of the donee is that they must make decisions in the person's best interest. If they make decisions which are not in the patient's best interest, then actually the case can be flagged up to the Office of Public Guardian, who can actually then intervene. And in extreme cases, they can even displace the donee. So I think the fundamental principle is that any actions that are taken on a person who lacks mental capacity needs to be in their best interest, be it by the doctor in charge or in best interest decision making, or the family or whoever has the legal representative who has those powers. Yeah, I think just additional points I wanted to add there.
I will just chip in with a few ideas. The first thing is obviously the donee has powers up to the point of the disease is not a life-sustaining sort of treatment. And the other one, of course, if it's seriously deterioration, which obviously in this particular scenario, it doesn't hit that threshold yet. Yeah. So that's why we are a bit stuck, right? I mean, it is not that life-threatening that you will take over. The second issue really is, to a certain extent, to be fair, apart from the patient's wishes, which is, to be fair, one would argue she's not has capacity, there seems to be good alignment between what the doctors want and what the family wants. The family, for what it's worth, have been engaging with the surgeons, discussing the case with the surgeons, presumably thinking about how they can actually manage. And if they were to push ahead with surgery, benefit of the doubt would want to provide that level of care or support for the family. The surgeons, the psychiatrists also think that it's best interest that the patient actually had surgery. I guess the big dilemma here is, how do you do it in such a least restrictive manner that will honor the patient's resistance or refusal, and at the same time hopefully get the best outcome. And I think Vishal, someone in the group also said, do we know the sort of the markers, whether it's if we're talking about palliative, such treatment may be useful. So I guess it's more than just operate. I guess if we broaden our horizon and think about it, it's a shared decision making that is beyond just the operate or don't operate question, which the discussion ends up being very nice and rich. I'm cognizant of the time, and therefore I would want to actually give Vishal as well as Giles just some time to actually ask these particular questions. One big message you want to leave with the audience on how we, meaning from IMH point of view, NHG within the restructured hospital acute care, how we can actually improve coordination of medical care for seriously mentally ill patients. I mean, using this patient as a sort of example, and your worry about where does this person go post-surgery, what are your big wishes or what are your big take-home points? Just for either Giles or Vishal before we sort of try to round it up.
Vishal, do you want to go ahead? Then I can also review what the CEC advice was.
I think your CEC would be more comprehensive, but I think thanks. I think this case is an illustrative case which is directly at the intersection of how a surgeon faces dilemma when the patient is deemed to lack the decision. And if you ask me one message, I think most important is awareness of such issues, and only whether if and when we are aware, then we'll bring this to further forums. So I think clinical ethics committees are existing in hospital in various mechanisms. They can help an individual doctor, and not only the surgeon, but all clinicians. When they have a dilemma, they can resort to a structure like one presented by Giles, is a four-box structure, which will give some form of clarity. It may not give you yes, no, right, wrong, but it may actually eliminate some of the obvious wrongs and narrow down some of the right ones. So yeah, all clinicians should have some framework like four-box, and of course they can seek help of clinical ethics committee. I would caution clinicians to decant the decision making to psychiatrists. I think there's a clear no. Please don't refer to psychiatrists just for doing appendectomy or amputation or whatever. At the end of the day, the diagnosis of schizophrenia doesn't automatically make person incapable or lacking capacity itself. So that would be my kind of highlights for the session. Thank you.
I'll jump in here slightly before Giles, you close up. This is new. I mean, to be fair, psychiatric illness, the teaching of psychiatric conditions, all that is actually, unfortunately, not as robust as we would like it in the undergraduate or postgraduate sort of a space. So these are opportunities for us to interact, to learn from each other. But again, Vishal, don't refer for those issues, but please consult if you really need, so that we can collaborate and understand the patient better, understand the illness better, so that we can do better for the patients. So it's not to take over the responsibility, but certainly the understanding of the illness and how we can collaborate to help the patient be better is something that at least the psychiatrists are interested in doing. Giles, final words from you.
Okay, thanks. Before I sort of just share the CEC advice, I think I just want to sort of make a strong point for greater collaboration between our specialties, and because it's the same patient and we all want a good outcome and the best outcome for our patients. So if at the end of the day, psychiatrists can work closely with our other medical specialist colleagues in the service of our patients and for their better outcomes, I think that would be my hope, and we continue to do so. The other thing also is that, although it pains me to say so, there is still a lot of stigma and still a lot of biases with regards to mental health and mental illness. And sometimes patients with mental illness, mental disorders, sometimes do get treated differently, and to the point where they may even get second-class treatments or may not even have the same standard of care as someone without a mental illness. So my appeal would be that let us keep an open mind, that people with mental health issues and challenges are equally deserving of the full care that everyone deserves. So and not to be biased against them as needing perhaps less care or inferior care. So that's my personal appeal. So I just come to the CEC now. This CEC opinion was quite brief because it was specifically pertaining to that specific time when the patient was inpatient for stabilization of the schizophrenia. So the ethics committee at that time noted the material points that the patient was deemed as lacking mental capacity. And at the same time, the premorbid wishes were not known. And as such, the best interest decision would have to be taken by the surgical team. So in fact, and that may well be within the purview of the other hospitals' CEC. And so restricting its comments to IMH and to the hospital, to this patient, the recommendation was that they work closely with the surgical team to support that process to take place. And at the same time, fully optimizing the patient's treatment whilst in IMH, so that if her mental state were to improve, she would be in an optimum state if she regained capacity to participate in her own decision-making, but if not, to be clearer in expressing her wishes. Yeah, so I think that in essence was the CEC opinion that was provided. Over to you, Aaron.
Thank you so much, Vishal and Giles. I'll just answer one very quick question, a quick fire question from Brenda about can we disengage patients that are non-adherent? So there's a quick fire question. The answer is, of course, you can. The patients, if generally don't want to comply, there is no need to force the patient. But given the Mental Health Care and Treatment Act, as well as the Mental Capacity Act, when the risk becomes very high and they do not have capacity, then there's a duty to not just say you do what you want, and there may be a reason to actually engage those patients more deeply. So again, when the threshold and the risk becomes very high, then you may need to engage the patients and not just disengage because of that. So I'll close the webinar today. We have come to the end of today's panel discussions and Q&A sections for today's webinar.